So just as an overview for today, just briefly, I'll talk about, again, our situation with the pediatric neurology workforce nationally and locally, and then kind of focus in on the main reason for the talk, which is kind of optimizing how we can work together as referring physicians and neurologists to help in seeing patients for headache. We'll go over the general evaluation and management of patients with headache, whether we start with them or the PCP starts with them. Some referral guidelines that we put out, I think 2 years ago with the HHP that are available online, and how to improve our referral efficiency to help the most patients in the best way. So earlier there was a talk that we gave for HHP, and this is kind of stemming off that, where what were some of the challenges or responses from referring providers about sending patients to neurology. And so what triggered our referrals because of a complex neurologic condition or comfort with it, failing to respond to conservative measures. And in the scope of things that are referred, headaches or migraines were in the top 3 things that we typically see. And also a question about needing more tests. What are the challenges that referring providers articulated? Most of them said there's a long wait time, and that's unfortunately still the situation. In fact, it's probably even worse now, and hence the incentive for this talk. And some concerns about duplicating documentation and what's needed for the referral. And so the questions were, how can we help this? And as we know, we need more neurologists here. We've been working on some guidelines to refer, and I'll get to that again. So there's one that's available from HHP and other ones that I'll try and be getting out to more providers in the future, as well as guidelines on when to pursue imaging. And this is kind of a separate topic of when folks are sent to multiple providers, but maybe also does apply in terms of a patient with concussion, et cetera. So directing patients to the right provider. And so overall, the goal for us as a system is to have the right patients seen by the right provider at the right time. That would be the ideal, and that would be the kind of the overall goal for this presentation. But currently, while we love to help in the care of our patients with neurological conditions, there's a shortage of child neurologists nationally and locally. So as a consequence, wait times are very long. And unfortunately, although it was foreseen back in 2000, now we're past 2020 and faced with this shortage. So across the nation, there's a shortage in most states, unless you're in the Northeast. And in terms of having a 20% or more deficit of child neurologists, we have for sure more than a 20% deficit here in our state here. And so hopefully with this talk, we'll try and hone down on how headaches can be managed before they're referred, and what kind of patients should be referred after initial evaluation management is attempted. I would say headaches take up about 30% of all the referrals we get in general. In general, though, for our local community, we've had a number of neurologists move out of state or close practice in recent years. We were fortunate to have Nicole Hodgeboom join us, our nurse practitioner, who is helping with a number of our new patients with headache. And Dr. Tanaka has also joined us in the end of 2020. That being said, we are short at least 2 full-time neurologists, and so we're still operating at a deficit. And the rate of referrals has also increased. We used to get maybe 15 to 30 a week, 15 to 30 a month, but now we're like more in the 60 to 90 range. We don't have that many appointments, and so we have this accumulating deficit. And unfortunately, our wait list is like in the 300 patient range. And so we have a little bit of a crisis in trying to get the right patient seen at the right time. And so to improve efficiency for referrals in general, it's helpful to have a goal or a specific reason for the referral. Is it clarifying diagnosis? Is it helping with treatment? Is it trying to walk patients through the management afterwards. And it helps us a lot to help the patient and referring provider if we have the relevant notes available to start to see what's been done and what the history is up to that point to move forward. And if sometimes things are circled as urgent or tried to be thrust more forward as urgent, we want to know what makes it urgent and for what reason. So these are just in general reasons for neurology referrals, but one of them would be some concerns about headaches or new deficits or particular concerns that the parent or provider might have. And so having this information at the time of referral helps us to triage it in the most efficient and appropriate way. And so again, going back to this 2020 guideline, we'll kind of dissect this a little bit more, but because headaches were a challenge in terms of having, making sure we got the right patients at the right time for the right reasons, we tried to come up with a flow chart of how to approach the patient with headache and get them seen in the appropriate fashion. So going back to some of the headache referrals. So these are actual referrals that we are coming to our in-basket or through our fax machine. And so often for headache patients, the referral reason is headache. And again, we want to know, is it a diagnostic question, a treatment question, or something else that we're worried about? And when we get the referral, then we try and go back and look at what's the history and what's the documentation, et cetera. And so sometimes now with Epic patient messaging, someone will message their PCP that someone's had a headache, and the PCP's reply is neurology referral. And sometimes there's not even an exam. We don't even have history. And so this is going to be something that will totally clog the referral pipeline and really back it up. Another example is another reason for headaches for 2 years, and because of that was felt to be urgent. But looking back at well-child visits and other intermittent visits, headaches were never mentioned. And the patient on the visit said he had headaches for a couple of years, but just didn't mention it earlier. And then the plan was refer to neurology follow-up as needed. And so again, this becomes another referral in the queue, but we really want to try and get started on working up and evaluating these patients, and maybe they don't actually need a referral. One of our personal red flags with triaging is when the only note available is a well-child visit, and at that well-child visit they ask if there's any concerns, a concern gets mentioned, and then there's a referral. And so often if they haven't come in for the reason for a while, one has to be suspicious that, oh, they've been sitting on a referral level problem, which just happened to present itself at the well-child visit. And so in approaching pediatric headaches, please see the patient. Please take a history, a headache-oriented history, and help us by doing an exam. In part of the process, we want to check for red flags first. We want to check for serious conditions with potentially serious consequences, which might need more urgent evaluation. And then if we get past that and there aren't red flags, then we're looking more likely at a primary headache problem, which is completely something that as a PCP, we can feel comfortable managing and doesn't need subspecialty care. And then the other key thing is that it's not a one-time visit. So often for these kinds of conditions that are present themselves periodically or episodically and particularly need some lifestyle modification, as we know, even when we try to change things in our lifestyle, sometimes it might need more encouragement or coaching or reminders or follow-up and feedback to kind of really get on develop the right habits over time. Then, if these lifestyle habits are optimized and the headaches are still excessively bothersome to the patient, and we'll kind of talk about what is bothersome, then neurology referral seems to make a little bit more sense and have a little more utility in terms of something that we might be able to help out with. And so going back to that first question in the pretest, so headaches in general are common. I would say near everyone is going to have had headaches, and a fair number of patients will have had recurring headaches, which is not uncommon. And most times, these patients who have recurring headaches that are bad enough to bring up in a medical visit at a visit to the doctor, a lot of them will have migraine because migraine headaches tend to be bothersome. But serious pathology is very uncommon in headaches, and we'll talk more about that as we go along. But often that's part of the reason why patients are coming in, because they've heard of something, their parents have heard of something bad that was headache related. That's often the main reason for their concern. And so addressing that is actually part of the therapeutic process. You know, have we considered serious things that could present with headache? And so a while back, there was a survey of 851 pediatric patients. About 17% had some type of neuroimaging. And of these 851 patients, less than 1%, had intracranial pathology that needed to be addressed. 2 of them had pathology predictable based on their clinical findings before getting the imaging. And 1 was somewhat unexpected, but did have clinical manifestations that showed up at a later stage. And so just to try and put it in perspective, even if someone came into our clinic and complained of headache, and we had 0 history and 0 exam, the likelihood that it's a serious condition is low, and that likelihood gets much lower again with addressing clinical findings on history and exam. And so when we think of headaches, one of the first steps is to try and separate secondary headaches from primary ones. And so this gets a little tricky in a sense that primary headache syndromes are things that we just think about as just a headache problem intrinsic to the person that gets addressed in one way. But of course, secondary headache syndromes have something else causing the headache that might need to be addressed in a fairly different fashion. You know, which is more common? It depends if you're a lumper or a splitter. And so overall, when they survey patients with headache of any cause, you know, viral syndromes and strep infections, et cetera, are very common. We don't even really think of those as headaches. We think of those as conditions that have headache with them. But if we're to think of all patients with headache, you know, more often there's some underlying systemic infection, et cetera, that's provoking them. Secondly, primary headaches become the next most common thing that often is seen in a primary care office visit. And so we'll spend the majority of this time together trying to address these. More long-term kind of sort of secondary headache conditions may involve concussion, head injury, sleep problems, or mood and anxiety problems. And again, least often serious pathology. You know, how do we sort out these important but rare conditions that present with headache? And so going back to that algorithm, so in the beginning, first step, like we were trained, get the history and exam. And the headache history can be more focused, but does really take time. I think that's probably the biggest challenge in terms of kind of appropriately evaluating and treating patients for headache. Really requires time for a history. And part of that is getting objective measurements of what's going on. And so there's a tendency for patients or parents to say like, oh, really bad headaches all the time for so long, you know, and how long do you mean? Oh, really, really long time. You know, and that, you know, in their mind, it's been bothersome and it's been around for a long time, but a long time could be a month or a year, 3 days. And so we really want to kind of say, you know, how long is it lasting? Okay, it's not exactly the same every time, but what's a range? Like 2 to 4 hours or 2 to 4 days or 5 to 6 months, you know, trying to get patients or parents to give objective data is really important, because that's where we're starting from. And that's going to be our basis for comparison. Are things getting better or worse later on? If we don't do that, especially on follow-ups, there's a tendency, there's a bias for parents and patients to recall the worst thing that they remember and the most recent, which often is not a clear idea of what's, kind of the average or range over months or weeks. And so taking time to get that information is important and helpful. It's an investment in the future treatment and evaluation of the patient. And sometimes it does require patients keeping a log. And usually I try and kind of strike a balance, saying that it's a hassle to keep a log. You don't want to add things on your plate. But on the flip side, if the headaches are bothersome enough, they should make that effort. It should be worth logging for us to keep moving forward with the evaluation and treatment. And so again, we really want to characterize the symptom fully, as we were taught, in terms of provoking and relieving factors, situations that it occurs in, et cetera. And having more than just headache as the history. And so again, this is a lot of detail, which I'm not going to go into, but initially through the history, we're trying to tease out, are there other things causing the headache? How do we characterize the headaches? How do we characterize triggers for the headaches? How do the headaches impact daily activity or routine activity? What kind of treatments they've tried, and then proceeding with the exam. And so this is wordy and long, but actually doesn't take that long. And I sent Charnel actually one of our headache intake logs. And so we'd welcome, we're happy to try and share that. I tried to develop that when I was in practice, because I realized to be efficient and thorough with evaluating and treating the headache, it took a lot of history, but that would take a lot of time during the visit. And so giving folks time to sit down with these questions and think like, oh, how often does it occur? Like, how long did that one last? When's the last one you had? And taking that time to extract that history before they enter the room makes it much more efficient. So we've provided a copy of the log that we can distribute. B, we provided a copy of the headache intake history for them to fill out. And then C, if folks are on Epic, I can share my smart phrase, which is basically the intake form transposed into Epic, and you just fill in the blanks. And so the hope is that it'll make this kind of important but time intensive history taking more streamlined, both to obtain and to document.
Keith, can I interrupt for a second just with a logistical question? If folks are on Epic, would it be okay for them to just Epic chat you and ask you to share that with them, like from within Epic? Because I don't think we can post a link or anything on the website.
Sure, yep.
Okay, so Keith Abe, make sure you get the right Keith Abe. It'll have the address and say pediatric neurology, because the other one is like an IT guy or something. You don't want to ask him. He doesn't know anything about neurology. Thanks. Go ahead, Keith.
So you're going to get tired of hearing me say it, but history and physical, definitely an important investment for the evaluation process. And one thing that often gets kind of brushed over is if you think of LPQRST, location, quantity, quality, provoking, palliative factors, what are the setting, the rating things, and T is for time. And so timing, so important. I think one of the most overlooked parts in taking histories for our folks in training. And so not just how long, but how often, when in the day are they occurring, or is it a weekday or weekend? Is it morning or afternoon or nighttime? And then how has it been changing over time? So changing over time, so important. So, migraines, patients are sick. These are high peaks. They feel terrible, but then usually within hours, they're back to normal. Hours, maybe a few days. And so in this kind of really sick and yet episodic, normal in between headaches, that's pretty reassuring. Kind of more mild to moderate level headaches, kind of up and on, fluctuating over time, over a long over an extended period of time, more typical for tension type or anxiety depression. And then the one in the background that needs to raise a little bit of the red flag for us is the chronic progressive. So the last three have headaches all the time, but one of them today is worse than the day before, this week is worse than the week before, this month is worse than the month before. Every time we move forward, it's getting worse and worse. And so that's a different kind of time course. And so whether this is, days or weeks, this is something we definitely have to pay attention to. Sometimes if we're just in the front end of an episode, like say we looked at this time frame for this headache, that seems much worse than this time frame for this period of time. And so that's why, within the first few hours or minutes of a headache, it's a little bit hard to tell. But if we step back and look at a week or a month at a time, when we have more data, that'll help us paint a better picture. And so headache, sorry. What I meant to ask is if people could chat in their list of what they think are triggers for headaches. Things that we'd want to ask patients about or pay attention to as things that could be a provoking factor for headache. And then Chanel, if you can just read the list off later on.
Yeah, so we have poor sleep, again, lack of sleep, snoring, stress, dehydration, poor diet, dehydration, more diet and dehydration, lack of physical activity, excessive screen time. Yeah, that's what what everyone said so far.
A good list, and kind of the frequency parallels to a certain degree the relevance. So definitely stress, poor quality sleep, shifting sleep times, hydration, skipping meals are common. More typical for migraines, certain odors, menstrual cycle, bright light exposure, and certain foods may be some triggers. But one thing that's helpful, or two things that are helpful, are avoiding triggers and modifying lifestyle habits to address these can treat the headache. And so again, no tests, no medication, lifestyle modification. But first is identifying the correlation and identifying things that could be addressed in that way. And so this is going to be I'm just going to run through a vignette that I copied and pasted from a patient, but just to kind of, not so much for the detail, but for the illustration of kind of what would be involved. And so often for a patient coming in for headache, this is the EPIC template, and usually there's a bunch of choices for me. And this would be things that she filled out in her intake form. So she had, in this case, she had headaches triggered by a head injury, and giving the location, the characteristics, duration, associated symptoms, how often, what time of day, weekdays or weekends, what are things that exacerbate it, what are things that don't exacerbate it, because those can sometimes raise questions for other conditions, and how has it trended over time. I didn't put the dose, but often we want to say what was used, how often. And my usual response is if it's effective enough for you to continue in your daily activity, then it was effective. It may not make headaches be zero, but if our goal is to keep kids functional. But in this case, she was having some challenges at first. And so this is just not so much a focus on this case, but more an illustration of what, how we would try and approach a patient coming in with headache. And then a second big chunk is about lifestyle habits that they already have at the time, and mainly looking for areas that we could try and help with. This same patient later on, so just to, again, not belabor it, but to emphasize the importance. So sometimes folks will say, are you drinking enough? And they say, oh yeah. And are you sleeping enough? Oh yeah, he's sleeping regularly. And then when we ask the details, the patient's drinking 2 cups of fluid a day, sleeping at midnight, getting up at 5 a.m. because they have so much homework. And in their mind, that's enough. But from our, our perspective, clearly that's inadequate. And so sometimes it does, not asking them if they're drinking enough or are they sleeping regularly, but to get the specifics, because in their mind, it may be okay, but from our perspective, it won't be. And then again, trying to fish for other things that could hint for other secondary causes. We just have a list and they just check the box, yes or no. Relevant things are, again, at least 30% of adult migraine will start in childhood. And so that helps to know that there's a family history, and actually without having a family history would make us a little bit more concerned in some patients who are having acute kind of escalating course of headaches. And then from the exam standpoint, a lot of times, especially, when I was in pediatric training, we don't break out the neurologic exam. It's kind of tucked in there with eyes are an HENT and et cetera. And neuro exam might have something about reflexes or moving all extremities, et cetera. But in patients coming in with headache or a neurological complaint, we do want to kind of break out a few, be complete, I guess I would say, in the neurologic exam. So on one hand, we're looking for things that would, make us concerned about meningismus or sleep apnea, neurocutaneous conditions, and then, how's their affect, how's their cognition. And I would say the thing that we're most interested in and most often gets glossed over is, do they have sharp optic discs? Super important, would change the course of management from the day of the referral, but I would say not included 90% of the time. And then coordination. And so this is just to demonstrate what we would document. I wouldn't say that everyone has to put that on their exams, but at least we do want to address vitals, looking for other causes. Do they have a neurocutaneous condition that we may have been flying under the radar? Because that would definitely change the risk factor stratification. And then in an ER talk, I went to an ER conference that talked about assessing kids with neurologic conditions, and they said we only have less than 5 minutes to get the history and physical, and so what do we need to do to not miss something bad? And so their answer was, listen to them talk, watch them walk, and look in their eyes. 3 things that you don't want to forget. And so listen to them talking: mental status, mood and affect, aphasia, dysphagia, dysarthria. Look in their eyes, pupils, cranial nerve abnormalities, and especially papilledema, and then gait and coordination to make sure that there's not something, especially in the posterior fossa, which is what we're often worried about for pediatric patients. And so we got the history and exam, and as part of our history and exam, we're trying to exclude red flag problems, which would be an abnormal neurologic exam, increased ICP signs, focal neurologic symptoms, and or progressive persistent headaches. One thing that I think creeps in from our general medical training when we were learning about adults and kids of subarachnoid hemorrhage, which often gets the kind of the label of worst headache of your life, which is helpful in a sense that patients who have subarachnoid hemorrhages have extremely bad headaches that are just on a whole different stratosphere from their usual headaches, et cetera. Lifestyle habits, we already talked about optimizing. And it's going to feel like I'm beating a dead horse or a broken record, but so many times patients, when they first get seen, have unoptimized lifestyle habits, and they say, oh, the main reason for referral is medication not working. But I try to tell the patients, the best medicine cannot sleep for you. It will not hydrate you. It will not de-stress you. It will not exercise for you. And so we can't expect the medications to do these things that need to be addressed first. And so it can't, you get tired of hearing it from me, but I would say that is often the biggest pitfall and often the biggest way we can help them. That once they get it set, a lot of kids do much better. Another one is, I'd say there's a little bit of stereotype of the type A high achieving person who has hard to control migraines. And there's been a number where they list their extracurricular activities, and it's like, why are you taking, all this long history? Because, they're the National Honor Society president of this and 4 clubs, and they're doing AP this and that, and then they're doing this other sports, etc. And then, but we have these headaches that I can't get under control. And so sometimes the therapy is telling them, you got to figure out what's essential, and we're going to have to trim back your schedule, because you just tell me your schedule, you can't be resting enough, and you can't be having enough time for balancing things out. So I've had some patients where the treatment is you should, postpone this class, etc., or select, 2 out of these 5 clubs, etc. And again, all of these have low, no side effects, no prescription, but shouldn't be overlooked. Similarly, deep breathing, as cliche as it sounds, actually does have physiologic changes that it does to the body. So teaching the kids how to relax is important, more important than prescribing the right triptan. Again, not to beat the dead horse, but talking about it again. Then getting to the acute rescue medications, ibuprofen, Tylenol, or some combination, usually as first line, has good evidence for it. Folks have strategically, put migraine on their combination medications and made concoctions of combinations, but I'm not personally a big fan of it, because either there's medications to make you sleepy, and we know sleep is the magic treatment for migraine, or that might help with caffeine withdrawal, but on the other hand, could prevent you from falling asleep. And so often I'm not a fan of these combination medications. One thing we do want to avoid is opioids. They actually can exacerbate and migraine, and can, as you know, lead to other problems. Where does pain come from? So the brain actually can't feel pain itself. So pain comes from the meninges and the sensory nerve fibers on the vessels. So the brain is not the source of pain. The vessels and meninges are the source of pain. And then we know in migraine, there's some kind of dysautonomia, dysregulation of the brain's vasodilation and sensory input. And so there's not 5-HT, but 5-HT and CGRP are targets for the triptans and some of the newer medications, which are not approved in kids to help with migraine. So first, lifestyle habits. Second, rescue medication. They need to be equipped, and also to take an adequate dose. Sometimes they'll say that I didn't want to take the full amount because I didn't want to get dependent. Take it early. Don't wait for it to get to be a really bad headache. If you know it's one of those migraines, take it early, take it enough, but we want to watch out that they're not using it too often. More than 3 times a week for more than 3 weeks will set them up for chronic analgesic rebound headache, which is a different problem. Some of our, we do get some referrals where some pediatricians are comfortable prescribing triptans. I think that's totally appropriate to prescribe for migraine. I wouldn't prescribe it for other kinds of headaches, but I would prescribe it for migraine. It can be effective, and it can be combined. So if you want to use ibuprofen and a triptan, that's totally fine. In fact, they developed one with a different name, which really is just taking sumatriptan plus a NSAID. I won't get into the status migrainosus things because that's a different issue. And so for the management, I tell folks that the foundation of everything is lifestyle habits. They hear it every visit. Lifestyle habits. How's your sleep? How's your hydration? How's your urine look? Is it dilute? How's your stress level? How's your screen time? And then after all those are optimized, then we start talking about how's the rescue medication working for you. Because again, the medication won't work if the lifestyle habits are not optimized. And really, they shouldn't be referred to optimize the lifestyle habits. That's something that can happen before they get sent to us. Preventative medicines, a few pediatricians will start it on their own. I would say, I can understand this is less common. We're kind of getting to more of the tip of the management iceberg here, and or tip of the kind of pyramid, I guess, of management. And one thing that's important is it needs to be consistent, and it's not immediate. So some folks will say, 3 days, it's not working yet, or I'm taking it, 5 out of 7 days a week, not working yet. Got to be consistent, and it takes time to be effective. We have some guidelines that are in the works that are separate guidelines that we're trying to send out, but are getting reviewed by administration. Basically, it still hits on all the things that we just talked about: checking for red flags, getting a log, optimizing lifestyle habits, checking the papilledema, depression for sleep apnea. And then after all those are addressed, if they're still having bothersome headaches that affect daily activity in a consistent fashion, then we can try and help out. And I should open it up for more, I think, questions and discussion. Oh, also there's some nice reviews in recent years. Also, I sent to Chanel that she can email to folks if they're interested. Just different overviews of pediatric headache you can use as a reference. And again, for the referrals, please see the patient, check for red flags. If no red flags, history and exam, optimize the lifestyle habits, give them a rescue plan, and then follow up to make sure it's being implemented. If it's all being implemented and we know objectively that they are meeting those lifestyle goals, then we can try and take the next step from there. Oh. Should I recap the questions, Trina?
Let's see. I'm gonna launch them. Well, our old poll questions were on our old meeting, so
Okay.
everyone will get MOC credit. Don't worry.
So
I
just go
think
to the
suffering through that
They
experience.
suffered.
earns
You get
MOC.
your MOC and your CME, everything that you want. There you go.
A crazy day, but
Yes.
so basically for that first one, it's just that headaches are common, migraines are fairly common, and probably the most, because they're so sick, the most common reason of people having headaches that will come to seek medical attention. But serious pathology is rare. We still want to look for it, but we can be reassured that it's not rarely going to be what walks into our office. How to minimize headache? We talked about sleep and physical activity. They actually recommend, some well-meaning parents will say, like, you have headache today? How's your head today? You have headache today? And it almost facilitates the sick role to a certain extent. So in general, I try and encourage parents to just watch and see how the kid's doing. If they're running around and playing, it doesn't really matter if they have a little bit of headache or not. In fact, we want them to try and stay active rather than shut them down too much. Similarly, sometimes patients think like, oh, the exception would be for menstrual migraine. Other than that, we don't recommend taking pain medicines just in case you might have a headache that day. So every school, they take a ibuprofen before school just in case. I would not recommend that. Instead, prophylactic medications are meant to be used regularly to prevent frequent headaches, but they do have to be used regularly. So sometimes people get it confused, patients get it confused, and they said, oh, I had a headache, so I took the preventative medicine that day. Like, no, it's got to be on board all the time, and then it starts to downregulate headache frequency and severity. Then lastly, as you probably would have guessed, this is to try and equip folks to feel comfortable managing headaches, taking the history, realizing that with a good exam in history, and even without neuroimaging, we're not likely missing a red flag situation or something that needs more urgent care. And that although it seems like returning to that broken record kind of thing about lifestyle habits, I would say of all the ways to best help the patient, that would be if I had to choose one, that would be the most important. Thank you.
Thank you so much, Keith. Thank you for sharing so much information in so little time and for bearing with that awful interruption. We definitely will invite you back, I think, in a few months for a redo, just so that you can, if you have time, just so that you can actually have the opportunity to make it through without those interruptions.
Oh, no worries.
Lots of thank yous coming through in the chat box. If folks have questions, we can stick around for a few minutes. So far, just lots of thank yous.
Actually, if there's a future session, I think to make it most helpful for folks, if there's a future session, I would invite questions and cases. I want to address the things that are on folks' minds. Sometimes I feel like I'm telling a lot of folks stuff they already know, and probably the folks who really need to hear this are not tuning in today. So unfortunately, so I want to kind of try and meet everyone, you know, kind of what's relevant for them. So I would invite kind of polling folks, and then we'll try and run through a Q&A list next time.
I think that's a great idea. There is a question from Hazel asking if you would you want ophthalmology to see the patients to document the optic discs, or are you okay with like an in-office undilated exam?
Oh yeah, for sure. So, oh, I see. So, you know, one fear I had about putting that that criteria for the optic disc was, if folks feel like they can never see an optic disc, then there will always be an ophthalmology referral. But no, it definitely does not need to be a dilated exam. Basically, you see some disc margins that look sharp, and then you're done. And so that's all we need to know, and that will help us triage. On the flip side, you see some blurred disc margins, that's going to totally escalate things. So it's such an important fork in the decision management tree that I would say, you know, gets passed over. And then we're kind of nervous, you know, seeing these patients. We don't know if they have papilledema or not, kind of sitting in our waitlist queue. So no, they don't need an ophthalmology referral. It would be good to just have someone look at the disc though.
Yeah,
And then
I have another question and a comment. So Victoria recommends a panoptic ophthalmoscope. I have to confess, I bought one the first semester of medical school, and I still have never successfully used it. That was some of the worst, like $300 or $400 I spent in my life. Oh, Hazel, you and I.
no, also,
But there's also a question that I think is a really relevant one for a lot of us. So Victoria asks, what about use of OCPs in patients with migraine?
oh, good question. So sorry, just getting back to the panoptic. So when residents rotate through, and when I went to neurology training, I was terrible at looking at this. I didn't train it on it all. In fact, I didn't carry an ophthalmoscope my first day on rotation. They asked me where's my ophthalmoscope, and embarrassingly, I wasn't carrying it with me. But with practice, it's like riding a bike. The main thing I would say that for most folks who come through who have a hard time is that it's kind of invasive in terms of personal space. So, you know, I tell folks it's like looking through a hole in a construction fence, and then you want to see all the construction that's going on, but they're kind of like looking from this distance. And there's going to be just one kind of sweet spot where you get there, and all of a sudden the back of the eye opens up with the panoptic. And you don't need to be there very long, but you do need the patient to fix, because if they're looking around, it's like trying to, you know, look in that hole that's moving around. So usually the patients keep asking me about where's the crab, because I have a crab on the wall of my office. I say, can you look at the crab? Is the crab moving? Which of course it's not. And then in that few seconds is a time when I can just, you know, kind of get them to hold still, not look at, if they look at the light, then they shy away and they don't want to look anymore. So you tell them, don't look at the light, look at the crab, keep looking at the crab, keep looking at the crab, keep looking at the crab, and then you get to see it. So getting them to fix and getting close, I think are the two most helpful things. And then just practicing. I blinded my wife many times until I got comfortable with it. So, and then OCPs, tricky one. So helpful for menstrual related migraine for some patients, as is sometimes they'll take you know, ibuprofen the day or two before their period. The hard thing is in patients who've had, the rare patients who've had stroke, OCPs is like a hypercoagulable cause. And so I think when folks are prescribing it, you know, they got to go through the family history about DVTs and PEs, and of course, you know, hopefully our patients are not smoking, et cetera. But I guess I would consider it more for folks who had a high menses related trigger. In those patients, it can make it better. I would say the flip side is if someone's coming in who's on OCPs, who's having headaches, you got to add that on the, you know, monitor concern list, because sometimes, rarely, there can be things like venous sinus thrombosis and things like that that develop.
So you would kind of think of it maybe as your like second or third line option for management for most patients, even if they had menstrual migraines, or would you think of it as like a first to second line option for menstrual migraines, but not for others, regardless of gender?
Yeah, so I would put it as kind of more like in the, it's not going to be acute treatment, right? So it's going to be preventative. So if the vast majority of their migraines are debilitating menstrual related migraines, and I'd say, that would raise it up on the list. But I think it depends on how much is their balance. So, if they have like, 20% of the migraines menstrual related and 80% not, or even 50-50, then I would say like, maybe we'll just do one of the regular prophylactic medications.
Makes sense. Yeah, and Victoria followed up on her previous question by just saying she's unsure about using OCPs for contraception or menstrual symptoms rather than headaches for patients with migraines. So in terms of contraindications, do you have any quick thoughts on that?
I personally don't prescribe it. I often would say have the OB or PCP prescribe it, when we do use it. The contraindications would be, hypercliable, kind of family history, and smoking for sure.
But not necessarily migraines per se.
Oh, no. Yeah.
Okay.
Not necessarily.
All right. Thank you. I think we probably should go ahead and say bye now. We've had people dropping off a little. We did have a lot of great conversation despite what happened. And thank you so much, Keith, for sharing your knowledge with us. And we look forward to welcoming you back in a few months.
Thanks, everybody.
All right.
you,
Thank you.
everyone.
Bye.
Bye.
Thank you.